going to cover till 20th. So again, today is very interesting topic and excellent speaker in the form of Dr. Mahesh. He is there. And to pair with him to moderate, we have Dr. Manoj Jain from SGPGI. He is president of the Indian Society of Renal and Transplant Medicine, and he is again an excellent teacher and pathologist, and mainly specializes in this field of renal pathology. So we have an excellent pair of speaker and moderator today to enlighten us with the interpretation of renal biopsy, which is going a long way to help our postgraduates and budding pathologists, because this is very important, and day by day the renal pathology is increasing. So I now hand over to Dr. Manoj Jain to start the session. Introduce the speaker and start the session.
Thank you, Vasla ma'am, for kind introduction. Good evening to all executives of IAPM, panelists and distinguished faculty, and all participants. It is my great pleasure to introduce Dr. Mahesh. He is senior consultant nepropathologist at Manipal Hospital, Bangalore, India, and he is very renowned renal pathologist and very popular among our renal pathology fraternity. He did MBBS from Karnataka Medical College, Hooghly, and MD from PGI, Chandigarh. He has many fellowships, and area of specialization is nephropathology, renal transplant pathology, urology, oncopathology, and he has established referral center of excellence in nephropathology and renal transplant pathology in Manipal Hospital. He has authored more than 50 publications. He is excellent speaker and very popular among our renal pathology fraternity. And he will be talking just he has told me that he will be talking a very lucid talk, which will be very useful for all postgraduates. So now I hand over to Dr. Mahesh for his talk.
Very good evening to all of you. I'm Dr. Mahesh here from Manipal Hospital. Thank you, Dr. Manoj Jain sir, and thank you, Vatsala ma'am and Ashrantikar ma'am, for this opportunity to be here in this forum. The topic that I've chosen today is that of interpretation of renal biopsies. I'm sharing the screen. Are you able to see this?
Yes.
Okay.
We can see the screen.
Okay.
Just make it slideshow.
Make it full.
Yeah. So the kidney, as a renal pathologist, how do we look at the biopsies, or whenever there is a core biopsy sent for a medical renal reason? So the kidney is full of the nephrons and the tubules and the vasculature. So it's nothing but the extension of the vessels which carry blood in terms of excreting the waste and maintaining the electrolyte balance, as well as the autoimmune, the mechanism to keep a check on the blood pressure, the renin-angiotensin system, which is which keeps a check on the pressure. So the outline of this next 45 minutes or an hour or so would be that to kickstart the nephropathology sessions in as the weeks go along. I've streamlined this in terms of more for the postgraduates to recognize the normal histology, how do we process, and what are the stains that we use, the glossary of terminologies that we have to learn, and some basic aspects of the immunofluorescence. How do we look up and in the interpretation of the findings of direct immunofluorescence. I have a couple of cases as illustrative cases pertaining only to the nephrotic syndrome, although the other cases will be dealt in the coming sessions. And finally would caution where we should keep a check on ourselves. We should not go beyond in interpretation, highlighting some of the artifacts that I have come across. To begin with, the clinical patterns that the nephrologist or the physician would do a renal biopsy is to look for the structural abnormality to correlate with the clinical findings that he has encountered in the patient. So the syndromes could vary from the nephrotic syndrome. The definitions we can go and see, like in the nephrotic syndrome, there would be a proteinuria of more than 3 grams, and similarly the consequence of that as hypoalbuminemia and the hypercholesterolemia. And the other definitions of nephritic syndrome, the asymptomatic hematuria or the proteinuria, or rapidly progressive renal failure and acute kidney injury, and the renal failure which occurs over a period of time. So when he does the biopsy, he collates all the clinical information in a form and he delivers it to us to make a concrete correlation between the clinical findings and the histologic findings that we see. So in the clinical, we always have to keep in mind in the adult, especially the diabetes, whether it's there or not, the hypertension, the systemic symptoms, especially the SLE, which invariably involves the renal parenchyma. And in the labs, the complete blood count, the urine routine, which is the window to the renal parenchymal damage, uh, and the 24 hours urine protein leak, the viral markers, autoimmune markers, and the vasculitic serologies like ANCA serology and the anti-GBM serologies. And the plasma cell dyscrasia workup also can be kept in mind when we are looking at a elderly patient. Uh, of course, the nephrologist would do ultrasound before doing a biopsy to see the size of the kidney, which is contraindication if the size is too small to not to have the patient bleed if the size is quite small. So this is how the cut section of the kidney looks, and what we are given is that of a core biopsy pertaining to the cortex. So the when a needle goes into, and the needle biopsy which they use, the either a 18 gauge not needle or the 16 gauge. 16 gauge is more broader than the 18 gauge, so we get more number of cloms in the 16 gauge rather than in the 18 gauge. So whenever they do the biopsies, they have they kind of split each of the cores, and they divide as mentioned here, one portion for the light microscopy and one portion for the immunofluorescence, and both the tips of each core is subjected for the electron microscopy in the appropriate fixatives. So the appropriate fixatives is very important, otherwise we end up in having many artifacts. So the pictorial diagram of how we look at the glomerular compartment, which is composed of the capillaries, the extension of the vascular system, in a small tiny caliber capillaries, which is held together by the supportive meshwork in terms of mesangial region, and the cross section of at the filtration level is by this basal membrane of this capillary. On the inner side is lined by the endothelium, which is interrupted by the fenestrations, and on the outer side it is lined by the tentacles of these podocytes, which kind of wrap up the capillary walls across. So the and this is the ultrastructure level of the same basal membrane, which is composed of 3 layers: the lamina rara interna, densa, and the externa. And on the outer side is these tentacles and the fenestrations of the endothelium. So coming to the normal histology of the glomerulus, it's lined by the Bowman's capsule, which is lined on the inner side by the parietal epithelium, and beneath that is the urinary space or the Bowman's space, and the capillary tufts, which are forming lobules, are formed of are composed of these capillary walls, and on the inner side is that of the endothelial cells, and on the outer side, these are the visceral epithelial cells or the podocytes. So, as you see that in each of the glomerulus, the lobules would be there. I mean, in terms of differentiating from the other uh, capillary walls. So in each of the two-dimensional cut, there would be around 6 to 8 lobules. Of course, we are not looking at the three-dimensional picture. In a normal histology. So any increase in the lobules would be regarded as a lobular accentuation, and the different anatomical landmarks of the glomerulus is that of vascular pole here, which is in which you see the two arterioles, like here the afferent arteriole, which has the media in the vessel wall, whereas the efferent is more of a thin, and the distal tubule which comes here has the lining which is close to the nucleus, or line close to each other, called as macula densa, and the mesangial matrix which is in this area of the vascular pole is composed of the matrix as well as cells forming the juxtaglomerular apparatus. So if there is an increase in number, then we, of course, we ask for the levels of the blood pressure. Anything more than cellularity of around 15, there's no hard cutoff that juxtamedullary hyperplasia. It's a more of a subjective finding. Like this, I would definitely call it as a hyperplasia of the JG apparatus. So these are other pictures where the vascular pole, the efferent arteriole, and the lining of this Bowman's capsule will continue as the proximal tubule, which has the nuclei that are distantly placed, and the brush border on its lining on the luminal aspect. So coming to the things that we do at the histopathology lab is to cut thin sections of the core between 2 and 3 micron thickness, and we subject the tissues in multiple step serial sections. The recommended is more than 24 or 26, although we normally go up to the level of 40 step serial sections, and stain alternatively the HNDPS, Meson, silver, and so on. So the usual stains are that of PAS, silver stain, Meson trichrome, and of course Congo red in the nephrotic illness. Rarely used are the Prussian blue and the oil red whenever the case demands. And for a renal pathologist, the special stain is HND, because that's gives us very less clues, and we don't use it that as far as diagnostic. Although we get that stain done routinely, but the information drawn from that is very specific to one or two things that we will come across. So the hierarchy of the flow algorithm in interpreting is to start with the glomerular compartment, and then the tubular interstitium, and then vascular. This would differ in case of interpretation of the transplant biopsies at the morphology level, where the tubular interstitium gets the precedence in terms of graft dysfunction, which when it is done in early transplant period. So the stains that we infer here are the PAS, Jones, and Mesons. The examples are given here. The basal membrane is stained reddish or the magenta color in the PAS stain, and in the silver they look like a very jet black in color, and in the Meson trichum the basal membrane stains bluish in color. So you can go on to this table later on as well. So coming to the PA stain, that's oxidizing agent, which particularly highlights the collagen type 4, which is seen in the basal membranes of the capillaries, the Bowman's capsule, and the tubular basal membranes. It also highlights this fresh border, as you can see here, of the proximal convoluted tubule. Even in the obsolete glom, this stands out very brisk magenta color, and it is different from the collagen which is deposited here in the Bowman space because of the different type of the collagen that is seen in the Bowman's cap space. So the glomerular tuft is the one which are composed of the type 4, and that stains magenta. So as I said earlier, it's the proximal tubular basal membrane is highlighted here, and similarly the fresh borders of the proximal tubule. In the PAS, the structures which we don't easily recognize is that of the lipid contents in the podocytes. Whenever we get to see a suspicion of Fabry's, that these do not stand out very clearly in the podocytes because of the nature of the contents. And similarly, whenever the mesangium is expanded by other structures like amyloid, this doesn't stain that brisk as compared to the Bowman's capsule, what you see here as the internal control. So it's very weak in picking up the lipid as well as amyloid. Coming to the silver stain, it's kind of basically the same. What highlights the PAS, the basal membrane, but the color would be different. As you see here, the black color staining the basal membrane, and in cases of membranous, you can see this spikes, which are basically the extension of the basal membranes, and in between those which are gaps are seen, though these are the areas where the subepithelial deposits would be located, and these do not take up the silver stain. In cases of membranoproliferative GN, you see this double contour as a tram track appearance in most of the capillary walls. These are the abnormalities that can be easily picked up by the silver stain. The meson trichrome, which highlights the immune deposits, the plasma proteins, and the fibrosis. That's the plus point of meson trichrome stain. As you can see here, this is a case of a lupus where the wire loop lesions, the subendothelial deposits are positive for the trichrome as a bright crimson red color, and similarly the hyaline globules of the immune deposits seen in the SLE are stained here as very bright reddish in color. In cases of membranous, again here just the location of deposits is different. You can clearly demarcate that there is a blue lining here which is basal membrane, and the deposits are seen on the outer aspect, whereas in this case the basal membrane is on the outer side, the deposits is beneath the basal membrane. So that's the plus point of meson trichrome. This is even to some extent it replaces the need for electron microscopy in very easy kind of go cases where you see this deposits in the subepithelial space in a case of post-infectious glomerulonephritis. So the other positive side of the meson trichrome is to differentiate between the active necrotizing lesion versus a healed segmental lesion, which looks on the hematoxylin in eosin both might look as eosinophilic, and if there are no karyorectic debris, then there would be a doubt of what could these be. So in the meson trichrome, if it is fibrillar and fibrillar in nature, and then the reddish, it's more of a necrotizing lesion, whereas in the segmental solidification, it's just the replacement of the collagen, which appears as bluish in color. Again, the fibrous component of the fibrous crescent can be highlighted better in the fibrous stain. And the most important prognostic finding is better appreciated in the trichrome stain. As you see, the sclerosis or the fibrosis which is spanning almost all throughout this core with hardly any few viable tubules here. RBCs, the best stain would be that of hematoxylin and eosin, where you see this tubules which are packed with the RBC casts. And next would be the meson trichrome. The stains which do not highlight it better are the PAs and the silver stain for the RBCs. The amyloid stains, I mean, I would go more for the meson trichrome and the congruent stain because of the color that it imparts in the trichrome, as well as in the congruent stain, congophilic nature. Here you see that this is a PAS which is negative, and this cotton wool appearance of almost like a sky blue appearance, and the silver stain is negative in these amyloid deposits, and one can even see the spikes which are emanating from the basal membrane of this capillary wall towards it at the periphery. So the congruent stain, of course, when it is polarized, it gives apple green birefringence. And other rare stains that we encounter are the Prussian blue, to look for if there is any iron deposition, iron pigment deposition in the tubules, or in the macrophages in the interstitium. So the scenario would be different here. This is a case of PNH in where the hemolysis is occurring and the deposition is in the proximal tubules. So as I said before, the hematoxylin and eosin is very narrowed down kind of thing, where we would look for the polymorphs because of the segmented nuclei, which is giving a very contrast color to easily pick up these segmented nuclei in a case of PIGN, or in a pyelonephritis. And even the eosinophils, the granules are better seen in the H&E stain than in any of the other special stains that we do. And another case would be that of where the oxalate crystals can be seen to some extent clearly in the H&E stain, but not in the other special stains. So for lipid, in cases of any metabolic diseases, we tend to do oil redo stain in the frozen tissue that is sent for the direct immunofluorescence to look for if there is any positive structure which are seen in the podocyte cytoplasm. Having gone through the stains, the nephropathologist would always come across with the various terminologies like focal and global, hypercellularity, whether it is limited to endocapillary or the extracapillary. So we'll just go through the definitions of each of this. Diffuse, when you see that more than 50% of the gloms, like here around 12 gloms are there, more than 6 is abnormal, then you call it as diffuse. And if there is anything less than 12 gloms, then you attribute it as a focal process. And if the abnormality is seen all throughout the tuft, then it is global, whereas any portion of it and the rest of the thing is viable, so then you apply the term as segmental. So these things would be the prefix to all the terminologies that I'll show you later. The mesangial hypercellularity is limited only to the mesangial stalk. Normally, in a normal thickness of less than 3 micron thickness, section thickness, the cellularity of mesangium would be up to 3. Anything more than that, we kind of categorize it as mild, moderate, and severe degree of hypercellularity. Like here, it's almost like 7 to 8 cells. So in this case, it would be moderate to severe kind of a proliferation of mesangial cells. As I said, the proliferative component, whether it is limited only to the capillary walls and the mesangium, where we apply the term as endocapillary, and the composition of the proliferative has to be mentioned, where like in terms of whether it is purely the endothelial cells that are clogging the capillary lumen, or is it mixed with the polymorphs in addition to the mononuclear cells and the endothelial cells, or it's purely exuberant infiltration by the neutrophils, as in case of a post-infectious GN. So sometimes in most of the cases the abnormality would be uniform across the glomeruli that you see in the core, but the secondary glomerular diseases, the prototype would be that of a SLE. You tend to see various pictures in the different glomeruli, spanning from one glomerulus might show only the mesangial abnormality, and some of them may show the endocapillary proliferation and the hyaline globules and the wire loop lesions, as you see here. Within the same glomerulus, you can see the partition of endocapillary proliferation on the right hand side, and on the left hand side it is purely that of the wire loop and the hyaline globules and the crescents in few of the gloms. So this kind of a pleomorphism, it's more or less you're trying to anticipate that the autoimmune serologies would be positive for ANA or dsDNA. The extracapillary hypercellularity. So extracapillary, as we mean that it is outside of this glomerular tufts, outside of the base capillary walls, that's in the Bowman space. Anything proliferating in the Bowman space, we call it as a crescent. If it is coming from the parietal epithelial cells, then we call it as true crescent. But in some cases, the proliferation would be that of stemming from the podocytes here, where we call it as collapsing GN or a collapsing FSGS. Here, the crescent is occupying the entire Bowman space, call it as circumferential, or if it is only occupying some portion of it, then it's a partial. Always try to look for the aging of crescents, whether it is pure, all of the gloms have this active kind of crescents composed predominantly by the cellularity, or if it is mixed with some fibrous element or as a fibrocellular, and in the late stage, it would be completely replaced by the fibrous tissue, thereby giving a clue to the clinician that it is not going to revert back. And in case of these crescents, always try to look for the underlying capillary tuft morphology, which gives us a clue towards what could be the etiology. And also the final details of rupture of the basal membranes of these capillaries, which gives us a clue towards a more vasculitic kind of a nature, as in ANCA associated GN and the necrotizing lesion. And also you can appreciate here that the other tuft within the same glomerulus does not reveal any abnormality. So this is a very typical of ANCA associated GN. Similarly, here in this, the Bowman's capsule is completely ripped off. Hardly any remnant of the Bowman's capsule is seen. So this is again goes with the ANCA or the anti-GBM kind of a glomerulonephritis. So as I mentioned earlier, the Bowman space, which is occupied by hypercellularity, but stemming from the lining of these podocytes, where you call it as podocytic hyperplasia with collapse of the underlying tuft, you tend to name it as collapsing glomerulopathy, as these are the terminally differentiated podocytes which are regaining its proliferation and occupying the entire Bowman's capsule, the Bowman space. So this is kind of anything hyperproliferating within the Bowman space is kind of a critical alert, and the etiologies could be the ANCA associated, where you don't see any positivity in the IF, or the immune mediated, or the anti-GBM mediated. So the nodular lesions, as you see here, the differentiating point of the typical exam going question of the DDs of nodular glomerular sclerosis would be that of a diabetic, where you see these nodules of various shapes and the sizes, within the glomes, whereas it's more of uniform in cases of MIDD. And these both are the PS positive. And similarly in the MPGN, which is forming the lobular accentuation, would also have the hyperproliferation of the cells, the endocapillary, as well as the mesangium, and the nature of this splits in the basal membrane. But in the PS, it would be negative in cases of amyloid, although you go on to the next set of stains as mentioned here to further tease out what could be the etiology for these nodules. So the other pattern of injury in the glomerulus would be that of a mesangiolysis. It's basically the microvascular injury at the capillary level due to hypertension, severe hypertension, or you can see the fragmented RBCs in the feeding arterioles, whereas the mesangial region is getting dissolved into multi-layers. The capillary walls also show double contours, and the trichrome here shows the fibrin capillary lumen thrombus. So the prognostic findings, the list here mentioned in the on your left hand side is the one which is amenable for the treatment, that's kind of reversible, whereas on the right hand side these are more of chronic lesions which do not regress. So coming to the immunofluorescence, so the tissue that the nephrologist would prefer to send it in for the immunofluorescence is the Michel's transport media. Although if you are closer to the lab, you can even send it in the saline. And the four things that we have to keep in mind in the reporting is the panel of antisera that you advocate in your lab, the routinely used are the IgG, IgA, IgM immunoglobulins, the complements C3 and C1q, and the light chains kappa and lambda. Fibrinogen is optional, and in very rare instances, very few labs have the fibronectin as a diagnostic immunofluorescence. The pattern of deposits is very important. The deposits are either granular or a linear, and if none of them, then you give it as negative for immune deposits. Or if it is less than 2 on a scale of 0 to 3 or 4, I usually use the scale of 0 to 4. Anything less than 2 is called as pauciimmune. And the location, so whether it's limited to the capillary wall, mesangium, or the extraglomerular deposit. So here is one of the example where you see this is a glomerulus which is stained with the IgG, and it's negative. The capillary wall or the mesangium doesn't light up with this antisera. And few other examples of negative immunofluorescence. These are the circled ones, which are glomeruli, which is completely negative. Some internal control, the plasma proteins, which are in the proximal tubules, can be positive with the immunoglobulins. So that serves as an internal control. This is a case of IgA nephropathy where the granular deposits, the nature of deposits is granular, and it is predominantly limited to the mesangial region, although very few can be seen even in the capillary walls. And the majority of the capillary walls are negative, and the score, the intensity of this score would be that of 4+. It's glaring at us, so we need not look for the intensity of positivity. It's graded as 4+. So here, this is another disease, membranous nephropathy, where the deposits are uniform and they are lining up the capillary walls and not having anything in the mesangium. So this is usually seen with the IgG and the granular deposits, and the scale intensity scale would be that of a 3+. So in case of post-infectious, then the granular deposits with the C3, complement C3, is kind of irregular. Even in the shape of this, I mean, the size of these granular deposits could vary, and they are not uniformly located. They are coarse and they are irregularly placed in the mesangium as well as capillary walls. And sometimes they form coalescence to give us a garland pattern, which is basically the worst prognosis in the immunofluorescence finding for post-infectious GM. So yeah, you are seeing the granular deposits. Now moving on to the linear deposits, which one would encounter in a good pasture syndrome. It's the IgG which lights up along the capillary walls, similar to the pulmonary basin membrane when the patient will have hematuria and hemoptysis. Depends on how bad is the damage done in the pulmonary as well as the renal system. So here again, on a scale of 0 to 4, it's scored as 3+. And you can see here the Bowman's capsule is also positive. And in some cases of anti-GBM, even the distal tubules can also be positive, the basin membranes of the distal tubules. So in the autoimmune disease, which is a secondary glomerular disease, you can have the full house pattern of deposits, the IgG, which is predominant among all the full house. So they have along the capillary walls and the mesangium, even the IgA. Here the intensity would be different. This is almost like 3+ to 4+, and here you would call it as 2+. And the complement C3 is 3+, and the C1q is also very bright. So the C1q positivity would always ask for autoimmune serology to be done if not done in the earlier workup. The presence of extraglomerular deposits along the tubular basin membranes of these granular deposits with IgG is almost always indicating that of a secondary glomerular disease in terms of SLE. Invariably, they will have glomerular full house pattern. So we always try to look for the extraglomerular deposits. That gives a hint that it is not a primary glomerular disease. So that's the value inferred from the presence of extraglomerular deposits. In the light chains, whenever we see the IgA nephropathy or the membranous, the kappa and lambda would try to simulate the deposits what we have seen in the immunoglobulins. So thereby these are polyclonal. Whereas in a monoclonal disease, depending on the nature of abnormality in the individual compartment of the renal tissue, if the gloms are affected by any kind of deposits and have a light chain restriction, that one of the light chain would be negative and the positive for kappa here and lambda negative. Similarly, in the tubular casts is brightly positive for kappa and the negative. So all these examples, say this is a case of amyloidosis. In the vessels, you see more intense staining for the lambda than the kappa. So this almost nails down the diagnosis of monoclonal disease, and the pattern of injury would be based on the histology findings, whether it is cast nephropathy or a glomerular disease in terms of light chain deposit disease or amyloidosis or any other sort of unique features of plasma cell dyscrasia. So the importance of kappa and lambda in the immunofluorescence has its own value, because most of these cases, in almost 1/3 to 1/3 of cases of plasma cell dyscrasias would have a negative serologies. So this becomes crucial from the renal biopsy, and it's imperative to have the kappa and lambda in the panel of antisera. This guidelines for how one should report the immunofluorescence findings. So some of the couple of illustrative cases pertaining only to the nephrotic range proteinuria. This is a child who has come with a relapse of nephrotic range proteinuria. You can see the edematous appearance here. He has been earlier treated. The nephrotic syndrome in the first decade is not usually biopsied. Only in cases of steroid resistance or a relapse, multiple relapses, then the patient is subjected for renal biopsy. This is one such case who has a relapse of nephrotic range proteinuria with the bland sediments and the normal renal function, typical of nephrotic syndrome, basically. So the scanner view of this tissue has almost 60 gloms in this, and the histology of each of the glomerulus was looking almost near normal in histology. So this is one of the disease where we spend a hell lot of time in figuring out, is there any abnormality in out of all these 60 glomerulus, which is cut at different levels, almost 40 sections. So the maximum time spent by us is in giving a diagnosis of minimal change disease, which is in this case. The immunofluorescence is negative for all the panel, the routine panel, IgG, A and M, and the complement C3. The C1q is negative, and so are the kappa and lambda. In the electron microscopy, this is the case of an index patient, where one would see, if you can recapitulate the normal as here, the podocytes, they form a kind of a tentacle kind around this basal membrane, whereas here it is lost its normal structure. It's completely effaced, abutting all throughout the basal membranes, so leaking out the protein to the massive degree. So the minimal changes is, it's basically the podocyte damage, the podocytopathy, which in young children they present with the typical nephrotic syndrome, and the protein leak that these patients have is almost always selective proteinuria, albuminuria, and that's how these patients will have complications of severe hypoalbuminemia if it is uncontrolled. In adults, the protein leak is non-selective, and these patients may or may not have the hypertension, and in elderly patients, they may have even acute kidney injury as well. So most of these elderly or the in adults and elderly, these are the common associations, apart from the nephrotic range proteinuria in minimal change disease. The deviations of these podocytopathies, where we, as I said, we really involved in looking for any abnormal glomerulus. If there is one glomerulus which has an abnormality, and we try to name it by the Columbia classification according to the criteria set in by the experts. So this is the tubular pole, and if there is abnormality here at the tubular pole of this glomerular tuft, then we call it a stip, whereas here it's at the vascular pole, which is next to the perihilar region, so perihilar variant. And if there is foam cells which are completely obliterating the lumen and the segmental sclerosis crowned by one single layer of podocytes, it's cellular variant. Whereas if there is a hypercellularity of the podocytes, then it is called as a collapsing variant of FSGS. So this is an algorithm for the the surrogate markers for hidden FSGS. So, I think there is disturbance of from one of the participants. The renal biopsy, we look for the interstitial fibrosis and the tubular atrophy, and this has we have to look for, depending on what's the age of the patient. As if it is seen in the children, it straight away implies that there should be some degree of segmental sclerosis in the vicinity if it is not seen in the biopsy.
1 second, Dr. Mahesh, 1 second. The participant, please mute yourself. I think someone is on. Dr. Ranjan, you please mute your mic. Please mute your mic.
हेलो हाँ मैम
Yeah, mute your mic.
मेरे यहाँ से मेरे में तो म्यूटेड है मैम आई एम सॉरी
Okay, thanks, Dr. Ranjan. The interstitial fibrosis and the tubular atrophy, if it is present, then it indicates the presence of FSGS, especially in the children. And the glomerulomegaly, like if you see this graph, a normal glomerular diameter, of course, it ranges from 160 to 200 microns, and when we measure in an objective lens, objective piece, like if it is crossing more than 1.5 times, or as you see here, the chance of the patient having FSGS is significant if there is a glomerulomegaly. So we go by the number of glomeruli that is sampled in the given case, the location of the glomeruli which has abnormality is also important, because the FSGS is one lesion which can be easily missed out if the sampling is not adequate, and the FSGS can start, or the earliest feature of FSGS occurs in this zone of juxtamedullary cortex. So the presence of this tissue, the juxtamedullary area, is very important in picking up the early lesions. And as I said, the number of step serial sections has really enhances the diagnostic ability. In most of the times, I have seen that the abnormal glomerulus is always seen at the last slide, at the 8th slide, and that too after spanning almost 30 sections. So, I mean, the step serial sections, as you see here, it's like trying to solve the magazine picture, like spot the difference between these two pictures. So here, this is one such glomerular lesion where the podocyte abnormalities are there, and the mitosis is seen in only 1 or 2 sections, but not in all. So that's the importance of following the step serial sections to look for if there is any peculiar finding which gives us a clue that this has regained its proliferation, so that's a podocyte damage primarily. So the second case is that of a adult non-diabetic who has developed new onset hypertension with a nephrotic range proteinuria, and the urine shows bland sediments, having normal renal function. The complements and the viral serologies and the ANA were negative. So this is the histology, which is stained in the silver stain, and the trichrome, which is diagnostic of this entity, where you see that the capillary walls are thickened, and on the silver stain you can see the spikes which are spiking out from the basal membrane. And the basal membrane, where it is cut in the tangential way, there you can see this mottled appearance, or the craters, basically the unstained area of the deposits. So on the trichrome, you see these fusionophilic deposits on the outer side. So this is a clear-cut case of a membranous nephropathy. This is one of the disease, apart from the amyloid, where even a one single glomerulus is adequate to make a diagnosis. But in case of podocytopathy, it goes on and on with restriction of almost 25 gloms, but still you will have the 5% chance of missing the focal lesion. So this is the number of gloms, the power of adequacy of the sample in terms of glomerular compartment. So in the immunofluorescence of this case was showing IgG, which is capillary walls, and the C3. The kappa and lambda are polyclonal, just resembling what you have seen in this immunoglobulin G. And the subtypes of IgG, here you can see that there is positivity with the IgG4 and negative for all the other subtypes. So thereby meaning it's a primary membranous nephropathy. And in the ultrastructure, you see that this is the basal membrane. And on the internal side, this is just the fenestrations, nothing abnormal on the internal side. But on the external side, these are the electron dense deposits which are sitting in the subepithelial zones. And based on the ultrastructure, in the earlier books, the sub stages of membranous nephropathy is given, although it has no correlation, direct correlation with the chronicity of the lesion. But in earlier it was mentioned that the stage 4 would be less responsive to the therapy. So in the recent last decade or so, there are new autoantigens which have come up to list. The first one is that of a PLA2 receptor, which is a primary antigen, which can be seen here along the capillary walls by the immunohistochemistry, or one can even do the immunofluorescence. So there are different platforms, but we do here by immunohistochemistry. So this is a case of PLA2R associated membranous GN, which is PLA2, and in the immunofluorescence subtype, it's IgG4. So that's how the algorithm for a glomerulus which looks normocellular. Normocellular meaning by that there is no hypercellularity in any of the capillary lumen. And how do we tease about based on the morphology as a renal pathologist? We tend to look for the basal membrane thickness, and if the basal membrane thickness is accompanied by any increase in the mesangial matrix or the mesangial hypercellularity, if there is any segmental solidification of the given tuft, or it's just revealing the normal morphology. And later we go with the help of immunofluorescence findings and of course electron microscopy to tease out what is the pattern of injury. So all these podocytopathies, it's just the pattern of injuries. So earlier these were called as a diagnosis, but these are nowhere diagnosis nowadays. It's just the pattern of injury which has its clinical implications in terms of how the proteinuria and the extent of proteinuria, and the FSGS, the meaning that there is a cell death in the podocytes. So these are the ones among the podocytopathies which progress fast to the end stage renal disease. And that's the importance of looking for closely to pick up the FSGS in a in patients who have nephrotic range, proteinuria or the nephrotic syndrome in the first decade or second decade, and of course in the adult as well. The last aspect would be that of artifacts. Some of the pictures that I thought I'll share it with you because you should keep a check on where you should not overinterpret. So it's always a delight for us when we have multiple cores. Of course, it's difficult for them to poke again, but some of the nephrologists in some centers, they take multiple cores, and having 60 gloms is a perfect delight for us to report on the various glomerular findings or the tubular interstitium. In children, it's easy to get the more number of gloms just because of the volume expansion in evolution of the volume expansion in the renal parenchyma. The fixation is of utmost importance. To have this kind of sections, it's always advisable to use the 10% formalin buffered fixative. The composition which we have in our lab is displayed here. The distilled water, the composition, the proportion of each of this, so that the adequate fixation is maintained, and the tissue should at least be in the fixative for an hour or so before you take it for the processing. If there is a mistake from the clinician side, or if we in the lab we take the immunofluorescence core that is sent in the saline for the LM, then we will end up in looking at this kind of a structure of renal biopsy, where it's very difficult to make out. I mean, the tubular contents, it's uninterpretable because everything looks like ATN here, the degenerated epithelial cells or the cytoplasmic contents. It's basically, it should not be interpreted in my view. Glomerular compartment, to some extent, you can say that it is in this line or so, but you cannot get the finer details of all the compartments within the glomerulus. Whenever the saline tissue is sent, I always look for the silver stain. This is the stain which gives the maximal information among all the stains that we look up. So you can see the difference here of this case. So the basal membrane, at least you can make out some abnormality that there is a thickening, but here it's very difficult to interpret. And in the grossing, if there is a pinching artifact, like if we squeeze the tissue while taking it in the cow slip before we put into the processor, then we end up having this kind of artifacts. And if the tissue processor, if there is a glitch in the tissue processor, we may end up having not optimal spread out of this tissue, the fixation, which gives a thicker section. And here, at least we can make out that there are few neutrophils, but in terms of hypercellularity, whether it is mesangium or the endocapillary, it's difficult to judge the finer details. So this is the thick section abnormality, which we should keep a check on over interpreting. Again, in the section cutting, if the tissues are not adequately spread out in the floating bath, then we will have this kind of different angles of these folds, which can distract if it is like here spanning out through the glomerular compartment or in the tubular interstitium. So it's difficult to interpret these kind of biopsies. And in the stainings, if there is a muck in the stain and before putting the cow slide, you may encounter this kind of artifacts. But in other step serial section, these kind of deposits wouldn't be there. So these are all the things which we have to keep in mind. The earlier ones were the extrinsic artifacts, but there can be inherent artifacts also, like here the capsule, the renal tissue just beneath the capsule should be disregarded. We cannot count this as a disease process. It's just because of the vascular supply, they tend to have more number of sclerosed glom in beneath the capsule. So the subcapsular zone, the number of sclerosed gloms would not be counted when we take the percentage of glomerular sclerosis. So it's basically the conglomeration of the clinical findings, what we are seeing, putting the clinical context at the light microscopy level, the morphology level, and adding the immunofluorescence and the information gathered from the electron microscopy makes a perfect clinical pathology correlation to the nephrologist to start the therapy and look out for the response. So this is the slide which I would really encourage the postgraduates to keep in mind. The color-coded things, the nephrotic syndrome, then you're most likely to expect the podocytopathies or the membranous nephropathy. In an adult who has nephrotic range proteinuria, you also see the amyloid in this category. The nephritic syndrome, the proliferative component, because they are having more of a red blood cell cast, so that's kind of the proliferative component from the gloms, whereas the RPGN would have the crescentic. I believe there is a couple of sessions on all these aspects. So this is the slide which I advise the postgraduates to keep in mind so that it's easy in the exams. So with this, I end my talk, thanking all my teachers in this extended ISRTP family with whom I have learned, and now I'm happy to take any questions, if so.
Thank you, Dr. Mahesh, for a nice presentation. Your slides were excellent, and you have demonstrated in all stains, all morphological lesions, and their etiological interpretation. You have tried to take this talk very simple though it's a very bit complicated topic. So there are some questions. One question from Dr. Sasank: how to differentiate pseudo and true crescents?
The crescent, the shape of the cells, the hyperproliferative cells, although it is very subjective, the crescents trying to encroach upon the capillary tuft, underlying capillary tuft, whereas in a collapsing FSGS, the proliferative cells are more of a bloated ones with having protein absorption droplets in the podocytes. The amount of cytoplasm that has in the podocytes, it tends to maintain, whereas in the spindle cells or the spindly shape in the crescent, they do not have that amount of cytoplasm or the contents of cytoplasm. It's more of encroaching on the tufts. So I would say that. There are IHCs also.
Dr. Mahesh, please stop sharing your screen. You stop sharing so that all will come. Yes, good. Yes. Now, sir, ask Manoj, sir. Continue.
Yeah. So can you do some immunohistochemical markers to differentiate pseudo and true crescents?
Yeah, the podocyte markers can be done as in the parietal epithelium. You can also do the keratin stain to differentiate whether it is a podocyte hyperplasia or the visceral epithelial cells. I mean, vis-a-vis parietal epithelial cells.
There is one question from Dr. Ranjan Agarwal. Do you do serial section in all cases? I think you have demonstrated in your case number 1 and 2, because in membranous, in single glomerulus, you can make diagnosis. But you can explain better. Yeah.
Yeah, the step serial sections is we cannot get away with the step serial sections. The renal biopsies is all about the step serial sections. You have to go all throughout 26 step serial sections and stain in different special stains. Each of this, because you want to see the same abnormality in different stains. So that's the reason why you alternate the stains.
But Dr. Ranjan Agrawal means that you do serial sections in all cases?
Yes.
In every biopsy?
Yes.
It is recommended?
Yes,
or in some cases you can diagnose?
No. We never know given case whether it turns out to be membranous or minimal change or any other lesion. So it has to be done in all the cases.
So if there are any more questions from participants, they can write in chat box. I think there are only 2 questions. Okay? So talk was wonderful. I think everyone must have enjoyed, and they will all agree that you have tried to demonstrate everything very clearly.
Let me check YouTube if there are any questions. Let me check YouTube. Just one. Vasla ma'am can continue.
Over to panelist.
Check the YouTube. It was really a very nice, excellent lecture, very well explained. It will definitely be beneficial for even JR1s, 2 and JR2s who are just starting their career in pathology. And all the stains were beautifully shown here in the slides. As Manoj said, the first comment that all the slides were very clear, good sections, very beautiful and well described. So in between, I like to have comments from Dr. Mohanty. Dr. Mohanty, sir, senior most panelist, is here. Sir, your comments, please.
Thank you, madam. So I must congratulate Dr. Mahesh for beautiful picture slides depicting every aspect of morphology. Because why I am telling you, just in the early 80s, I have been trained for renal pathology in All India Institute for 10 days. So in that case, we learn everything, and capillary, cellular, non-cellular, or proliferative, non-proliferative, global, and diffuse, all these things. And one thing I will say, if you have good clinical history, biochemical findings, and the good stent, H stent slides, thin stent, 3 micron, 90% your problem is over. You can reach in the diagnosis, and rest 10%, you can go for this the fluorescence and electron microscopy very rarely. So this is the thing. This the pictures he has taken, the slides he has shown, so classical that once somebody sees it, so you will remember forever. So this is my revision. And moreover, our moderator today, we had the opportunity to chair a renal session, renal pathology session with Dr. Mehul Amin is a great nephrologist, then nephropathologist, renal pathologist. And in Hyderabad, both of us were there, Manoj and myself. So I enjoyed the lecture very much, and I'm sure it is very helpful for the postgraduates who are have attended this thing. Thank you, Dr. Mahesh.
Sir,
Thank you, sir. Thank you.
one question is there from Dr. Kiran K in YouTube. How to differentiate between periglomerular sclerosis and crescent? Dr. Mahesh, periglomerular sclerosis and crescent. How to differentiate?
So the periglomerular sclerosis, you see the deposition of collagen, the abnormal collagen around the Bowman's capsule, whereas in a crescent, it's more of I assume that it's fibrous crescent versus a periglomerular fibrosis, where you would get this doubt. In the periglomerular fibrous crescent, you look for the other glomeruli. What are the findings that are seen in the glomerular tufts or the Bowman's space? Then you kind to match up whether it is a intraglomerular finding or a extrinsic finding of the Bowman's capsule. And also the tubulointerstitial disease, that gives a flavor of whether you're looking at primarily a GN or a tubulointerstitial disease. This doubt in chronic tubulointerstitial disease, this occurs. I would say that this doubt would be there. So you go by the flavor of what is the other compartment's findings.
One question is from Dr. Prathna Saha. Do we consider mesangial cells as a part of endocapillary proliferation along with endothelial cells and leukocytes?
No, endocapillary is when the capillary lumen are
Mesangial cells
obliterated.
as a part of endocapillary proliferation. Do we consider? Yes.
Mesangial cell proliferation would accompany whenever there is an endocapillary proliferation, but I usually limit endocapillary proliferation to the cases where we have a compromise in the capillary lumen. So that is usually by the endothelial cells or a mononuclear cells or the polymorphonuclear cells. So the mesangial cell would always accompany that. But in cases of IgA nephropathy, it's only a mesangial abnormality. So we are not going to call that as an endocapillary proliferative GN. So endocapillary is only when there is a luminal compromise of the capillaries.
Dr. Nilesh, region for C3 and C1, complement 3 and complement 1Q. Can other complement work?
Sorry, ma'am, I didn't get the question.
I also couldn't get it. Nilesh Kapadia, region for complement 3 and complement 1Q. What is the region? Why they deposit? And can other complements work? Complement works means other complements can be deposited or not? Maybe he asked that.
No,
what is the region for only C3 and C1Q?
So if we look at the complement cascade, the activation of complement cascade by various diseases. So if we take, for example, of alternate pathway, the C3 would be the one which is dominant. So the C3 positivity would be there. And the C1q activation is by the classic pathway. So the diseases which go through this classic pathway will invariably having the C1q. The prototype would be that of a SLE. So it depends on what is the disease that is activating the complement cascade.
One question from Dr. Smitha. Which are the cases you go ahead and do IgG subclass in immunofluorescence? IgG subclass. Yeah.
Nowadays, it's recommended whenever you see the predominance of IgG, you do the subclassification of the various subtypes of IgG, but it is optional. Some centers do it in all cases, and some do not.
In which
Like
these
in
are
photocytopathies where we don't have the immunoglobulin, so there is no point in doing in those cases. But yes, if there is a predominance of IgG, then you tend to do the subtypes of IgG.
in membranous nephropathy, and there are many conditions.
Yes.
You would like to do.
Yeah.
So excellent talk, Dr. Mahesh. It was really good,
Thank you,
like Madam and Sir told, starting from very basic till went till too deep.
Thank you.
If you are a renal pathologist like Dr. Manoj sir, then you can follow everything. For us,
No, I'm chota.
that was really difficult.
Dr. Mesa is very good.
That was all the things were very good, and anybody can understand, and that was a nice thing about this lecture, that it was excellently, and pictures were good, because we can read anything in the literature until you see it. Once you see it, picture is in your mind, then it is very easy, it becomes easier to interpret. You can read anything in the literature, but you don't, it is a difficult thing. So any comment from
Madam, for the postgraduates, it was really good. They must have followed it, because it started from very basic like pathology.
JR1, it was very JR2, because they have to see it to understand this. Until they see, they can read that yes, we can do this stain, we can do this stain, but how it looks, until they see it, they cannot learn it properly. So that was the best thing. The odds are like all the stains were covered very well in every stage. And any other comment from any other panelist? Ranjan, Haren? I think today Siddharth is not there, Pradeep is not there.
Yes, madam.
No, ma'am. No, ma'am. It was a nice talk. No question.
Thank you.
Yes.
Very
So
good.
thank you. Madam, thank you.
Very nice. I enjoyed the talk like anything.
Yes, sir. It was very good.
Once again, a big thank you to Dr. Mahesh for sparing his time, and we will expect many more lectures as we get time subsequently. And
My pleasure,
Dr. Manoj Jain for sparing his time and moderating here and coming on this webinar. So once again, thank you everyone. Good night.
Good night. Good night,
Thank you.
everyone.
Thank you. Good night.
First, we will
Good night,
meet
ma'am. Good night, everyone.
on 11th.
Yes, madam.
Okay.
Edit. Once and